Good afternoon. Good afternoon. Welcome to the symposium of the how to adopt the current guideline of the atrial fibrillation. I am Dr. Nguyen from the Head of Cardiology Department, Yangon General Hospital, University of Medicine 1. I'm chairing this section. And then the first section, the first section is talking about the overview of the atrial fibrillation, management of the atrial fibrillation. The second section is talking by discussing about the how to prevent the stroke in the atrial fibrillation by the Dr. Telesi. Now I'm going to start my talk here for the overview of the management of the atrial fibrillation. Can you see my screen? These are my outline, definition, classification of the atrial fibrillation, and then risk factors, pathophysiology and clinical presentation of the atrial fibrillation, screening, diagnosis, and evaluation of the atrial fibrillation, integrated management, including the rate and rhythm control, and the detection and management of the cardiovascular risk factors and concomitant diseases. These are my outline. So if you look at the definition of the atrial fibrillation in the ESC 2020 guideline, is the atrial fibrillation is the one of the supraventricular tachycardia with the uncoordinated atrial electrical activation and ineffective atrial contraction. It's ECG manifestation of the irregular RR intervals and absence of the distant repeating P wave and irregular atrial activation. So that in 2020 guideline, ESE guideline, and the clinical atrial fibrillation is defined as at least the recorded atrial fibrillation is a minimum 30 seconds with or without symptoms. So what about the subclinical atrial fibrillation? Subclinical atrial fibrillation is the episode of the atrial fibrillation detected by the insoluble or wearable cardiac monitor, such as the CIED. CIED means a cardiac implantable electronic devices. So you can see here, this is the atrial fibrillation, the irregular ventricular contraction with the narrow complex tachycardia and rapid ventricular rate. So in ESC 2020 guideline, and the pattern of the atrial fibrillation is classified as a first diagnosed atrial fibrillation, is the first time diagnosis irrespective of the duration and severity of the atrial fibrillation symptoms. Paroxysmal atrial fibrillation is defined as it is dominated by or spontaneously or with the intervention within the 7 days. Persistent atrial fibrillation is the duration of the atrial fibrillation is more than 7 days. The episode is dominated by the cardioversion after the 7 days. Long-standing atrial fibrillation, persistent atrial fibrillation is the continuous atrial fibrillation more than 12 months and still having to consider for the rhythm control strategy. The permanent atrial fibrillation is that there is no further attempt for the restoration or the maintenance of the sinus rhythm. And both physician and patients accept the atrial fibrillation as a permanent atrial fibrillation. The 2020 ESE guideline does not use the terminology like the long atrial fibrillation, valvular, non-valvular, and chronic atrial fibrillation. If you look at the risk factors of the atrial fibrillation, you can see here the inner ring is the risk factor of the atrial fibrillation. Those risks are not modifiable. So genetic needs and gender and aging and then ethnicity are not, we cannot modify those risk factors. The outer ring, you can see here, there are many risk factors for the atrial fibrillation. Most of the cardiovascular diseases, heart failure, coronary artery disease, vascular diseases, valvular heart diseases, all the cardiovascular risk factors are the risk factors for the atrial fibrillation, also including the obstructive sleep apnea and the obesity, and also the major organ diseases like the COPD and the acute illness surgery and chronic kidney disease. Those are the risk factors for the atrial fibrillation. So if you look at the pathophysiology of the atrial fibrillation, two main pathophysiological changes is hypercoagulability, and another thing is the structural remodeling, particularly in the left atrial. The alteration as a result of the fibrosis, hypocontractility and inflammation, infiltration and vascular remodeling and ion channel dysfunction. These two pathophysiological changes causing the thromboembolism and heart failure with the preserved or reduced LVEF. And then clinical outcomes are the stroke and then consequences of the cognitive impairment, dementia, depression, and finally impair the quality of the life and hospitalization, and finally ends up with the mortality. These are the clinical outcomes. So if you look at the symptoms of the clinical presentation of the atrial fibrillation, some patients, they do not have any symptoms. So they are very stable with the hemodynamic. And then some patients with the, even though they're symptomatic, they are still hemodynamically stable, like people usually present with the palpitation, dyspnea, and tightness of chest, and sometimes and dizziness. And some patients, and then they have the hemodynamically unstable, and then they usually present with the syncope and the symptomatic hypotension, acute heart failure, pulmonary edema, and ongoing myocardial ischemia, and finally cardiogenic shock. So if you look at the 2020 ESC guideline and then screening of the atrial fibrillation, emphasize the screening of the atrial fibrillation because there are many novel tools for the atrial fibrillation detectable devices like the smartphone and the wearable watch and the touchable MIG devices. These are the very useful for the detection of the atrial fibrillation. So the recommendation of the screening to the detection of the atrial fibrillation and ESC 2020 is a class 1 recommendation. For example, the patient atrial fibrillation is detected by the palpation of the pulse of the ECG rhythm switch by any device after the age of the 65 year, or interrogation of the CIED by the detection of the atrial high rate episode and the detection of the atrial fibrillation. These are the class 1 indication. For the class 2A indication is the patient with the 75 years of age or the patient with the high risk of the atrial fibrillation using the systematic ECG screening to detect the atrial fibrillation is the class 2A recommendation. The patient with the atrial fibrillation, how to assess the patient with the atrial fibrillation is that you can see here, you should remember the 4S. The first S is the stroke risk and how to calculate the stroke risk, and by using the chest scope. This area will be talking by the Dr. Teles VA. And then second thing is the symptom severity, and then how to assess the symptom severity, and then we can use the, for example, the EHRA symptom scoring system. The third one is the severity of the AF burden. The AF burden is the duration of the AF and also the density of the atrial fibrillation. And then using the special report to the cardiologist or physician and using the 24-hour Holter monitoring is the simplest way to the detection of the severity of the atrial fibrillation burden. The final one is the substrate severity and the detection and identification of the cardiovascular risk factor as well as for the comorbidities. And then another thing is the atrial cardiomyopathy, detection of the atrial cardiomyopathy by using the imaging like the transthoracic echo and transesophageal echo or CT angiogram, and then you can using the biomarkers for the detection of the left atrial cardiomyopathy. So for the basic knowledge of these 4S and then all the atrial fibrillation patient and then medical history should include the AF related symptoms and then AF pattern, and then and you can find out the concomitant disease, concomitant condition, and then also calculate the chest score for the prevention of the stroke. And then all the patients should have the 12-lead ECG and then basic investigation, electrolytes and full blood count, also including the thyroid and kidney function. If available, transthoracic echocardiography is a very useful to assessment of the patient with atrial fibrillation. And some patient, and then you need to refer to the cardiologist or physician for the further assessment. And then selected patients should need the needed to be the further investigation, like the ambulatory ECG monitoring. The simple way is a 24-hour Holter monitoring for the adequacy of the rate control or the rates if atrial fibrillation related symptoms. The transesophageal echocardiography is also determine the valvular heart disease and then left atrial appendix thrombosis. And then also the clinical biochemical parameters, biochemistry parameters like the cardiac troponin, hsCRP, and then BNP, and then pro-BNP are also useful, and then cognitive function assessment is also need the patient with the atrial fibrillation. For the assessment of the coronary artery disease, CT, coronary angiogram, and then ischemic imaging are very useful. And then CT and MRI for the detection of the stroke patient, and then cardiac MRI for the using for the early assessment. For the after the assessment and the full then select the structural follow-up is very important, because the structural follow-up is to make sure the optimal management, adherence of the optimal management with the patient. And that done in the cardiologist, physician, and coordination between the cardiologist, physician, and primary care physicians are very important for the structural follow-up. So this is an example of the EHRA symptom scale, and they're very similar to the NYHA class, and also based on the normal daily activity. So what about the components of the integrated AF management? Integrated AF management is the patient-centered integrated AF management. Then these are the three important components. The first one is the optimize the stroke prevention. The second is the symptom control by the either rate or rhythm control. And the third one is the management of the cardiovascular risk factors and comorbidity. To achievement of these integrated AF management, and then we need to educate the patient for the risk factor control. Also need to educate for the healthcare providers for the how to do the structure follow-up. So there's all these strategies are to promote the adherence, medication adherence for the patient. So the multidisciplinary team approach is very important, and then structure follow-up between the clear communication between the primary and secondary care physician are very important for the optimal management of the patient with atrial fibrillation. So the 2020 ESC guideline mentioned about the CC to ABC. What is the CC to ABC? Is confirm the atrial fibrillation, characterize the atrial fibrillation by the assessment of the atrial fibrillation using the 4S, you should remember. And then the treatment of the atrial fibrillation is the ABC pathway. ABC pathway includes the first is A for the anticoagulation treatment, avoid the stroke, and B for the better control of the symptoms by the either using the rate control strategy or rhythm control strategy. The C is the identification of the comorbidity and the management of the cardiovascular risk, identification and management of the cardiovascular risk factor. So here is I just want to show you that how to use for the rate control therapy. Rate control therapy is the background therapy in all the AF patients. The first choice therapy in the patient with the minor symptoms, and also after the failure of the rhythm control strategy is that you can use for the rate control strategy. Sometimes and the rate control strategy is useful when the risk of the restoring the sinus rhythm is outweigh the benefit and the initial rate control is the linear rate control is the initial rate control is the heart rate less than 110 beat per minute. And then if patient has the stay symptomatic or the deterioration of the LV function, a patient with the CRT, cardiac resynchronization therapy, doesn't work for the patient, and then we need to bring down the heart rate to the 80 beat per minute, and then lower the heart rate in the CRT, aiming at the biventricular pacing, and patient during the exercise, 25% of the exercise, the minimum heart rate should bring down to the 100 beat per minute. So how to achieve that one, and then we can use for the 24-hour Holter monitoring for the safety. If you cannot achieve the rate control achievement, and then you should consider for the rhythm control or for the patient with the CRT, we should need to consider for the AV node ablation. So this is a simple algorithm for the rate control strategy, initial rate control strategy. The basic is that you need to know the patient have the signs and symptoms of the clinical heart failure, or the patient have the reduced LVEF. If you don't have the feasibility of the echocardiogram, it doesn't matter, and we need to use the chest X-ray to patient have the LV failure or not. If the patient doesn't have the LV failure, you can use the beta blocker or the gelgesand or verapamil and then calcium channel blocker for the rate control approach. And if the initial target heart rate is not achieved, and you can act for the junction. If the patient with the heart failure, you can start with the low dose beta blocker. If patient cannot tolerate the beta blocker, you can use for the immunodrone for the initial rate control. If the patient is not achieving the target heart rate, you can act for the junction. The important thing is that try to avoid the bradycardia. And after the rate control, and then you should arrange for the echocardiogram for the assessment of the chest vascular for the further plan for the further management. So these are the drugs using in the drug for the rate control. So I'm going to talk about the rhythm control approach. A rhythm control approach is that the main strategy for the rhythm control is to reduce the AF-related symptoms and improve the quality of the life. Before starting the rhythm control strategy, you need to make sure that there's a stroke prevention should be confirmed, and then rate control is the optimal rate control, and the detection of the cardiovascular risk factor and detection of the comorbidity should be performed perfectly. So after that, the patient still having the symptom, you need to assess that those symptoms are the AF-related symptoms or not. And the important thing in how to assess the AF-related symptom. So if you cannot do for that one, and then refer to the physician or the refer to the cardiologist. Who are the benefits from the rhythm control approach? A patient with a young age at the first episode of the atrial fibrillation, those patients with the atrial fibrillation induced tachycardia, induced cardiomyopathy, the patient with the early initial state of the early remodeling, and the patient with the minor comorbidities with the normal structural heart disease, and very difficult to achieve the target rate control. And these are the potential candidates for the rhythm control strategy. So if we have the rhythm control, and then how we do the rhythm control, we have the two approach, and then using the antiarrhythmic drugs or the ablation. So initial approach to the rhythm control is that we need to consider for the cardioversion. So consideration of the cardioversion is that basically for the basic on the how stable patient is it. So if the patient is an emergency situation, we don't need to consider for the other things, and then just give the anticoagulation and then do the electrical cardioversion. If the patient is a hemodynamically stable, you need to check the oral anticoagulation status of the patient, and then also need to check for the duration of the atrial fibrillation, how long has been the atrial fibrillation, less than 12 hours or more, between 12 to 48 hours or more than 48 hours. After assessment of those factors, you need to consider for the early cardioversion with the either pharmacological or the electrical delayed cardioversion or the elective cardioversion, and using the OAC status. So after the maintenance of the sinus rhythm, at least 4 weeks for the anticoagulation must be given. After that, and then you have to assess for the chest vascular for the long-term consideration of the long-term anticoagulation. These are the antiarrhythmic drugs. So indication for the long-term rhythm control strategy is that just to relieve the symptoms. So before starting the long-term rhythm control strategy, you need to assess for the how much the patient have the structural damage in the heart, and also the optimization of the cardiovascular risk factor control, and then optimization of the treatment of the comorbidity. So patients without structural heart disease, you can use the donadrone, flecainide, and propafenone and sotalol. The alternative is the catheter ablation. In Myanmar, also we have available drugs are the flecainide, propafenone, and sotalol. The patient with the coronary artery disease or preserved heart failure with the preserved LVEF, the significant valvular heart disease, and then you can use for the immunodrone, donadrone, and sotalol. The alternative is the catheter ablation. Patient with the reduced LVEF, the only drug is the immunodrone. So if we look at the catheter ablation, what are the class 1 indication for the catheter ablation is the patient with the paroxysmal or persistent atrial fibrillation with the recurrent heart failure due to the atrial fibrillation. We should consider either antiarrhythmic drugs or the catheter ablation with the recommendation of the class 1 recommendation. If you use the antiarrhythmic drug and then pay for the antiarrhythmic drug, and then you should consider for the perform the catheter ablation is the class 2A indication. Another class 1 indication is the patient with the persistent atrial fibrillation without major factors for the atrial fibrillation recurrences, failed medical therapy. You should consider for the catheter ablation as a first line therapy. So what are the factors and to poor outcome for the rhythm control strategy? So these are the factors, like major cardiovascular risk factor, hypertension, glycemic control, and smoking, hypercholesterolemia, and OSA, and physical inactivity, alcohol, using of the alcohol. So optimization of the comprehensive AS risk factor management is very important to optimize the outcome of the patient with either the rhythm control strategy, the support of the rhythm control strategy or the catheter ablation. So important thing is that to control the optimization of the cardiovascular risk factor control is very important. So this is my final slide before going to the summary. And you can see here the aim is for the management of the atrial fibrillation is the reduction of the mortality and morbidity. The primary prevention of the atrial fibrillation is the lifestyle modification. That means the cardiovascular risk factor management and risk factor for the atrial fibrillation management, and then treatment of the underlying condition. So these are the primary prevention. For the secondary prevention, addition to that, and the secondary prevention is a stroke prevention, the symptom control by the either rate control or rhythm control, and then comorbidity control with the comorbidity and the cardiovascular risk factors. This is for the secondary. So you can see the middle box as a atrial fibrillation risk factor. You can see here that some are modifiable, some are not modifiable, and some are the partially modifiable. For example, the concomitant diseases like the heart failure, COPD, and valvular heart disease and coronary artery disease, those are the partially modification, can do the partial modification. Aging and genetics and gender cannot do with the modification. If you look at the early remodeling, and early remodeling in the early remodeling is a reversible condition like the electrical, biochemical, and inflammation state. And then late stage of the LA remodeling is a non-reversible, for example, the fibrosis, scarring, and dilatation. Based on these LA remodeling, the pattern of the atrial fibrillation is paroxysmal, persistent, or permanent atrial fibrillation. The final outcome of the clinical outcome of the atrial fibrillation is the mortality, stroke, and dementia, impaired quality of life, heart failure, myocardial infarction, hospitalization, and finally for the burden on the healthcare costs. So I'm going to summarize my presentation here. The diagnosis of the atrial fibrillation needs to be confirmed by the conventional 12 ECG or the rhythm strip showing the atrial fibrillation duration equal or more than 30 seconds. There are many novel tools for the screening and detection of the atrial fibrillation substantially add to the diagnostic opportunity. The structural characterization of the AF, that means the assessment of the atrial fibrillation, you should remember the 4S to improve the personalized treatment. Integrated holistic management of the atrial fibrillation is essential to improve the outcome. The ABC pathway streamline the integrated care of the atrial fibrillation across the healthcare levels and among the different specialties. Rate control is an integral part of the atrial fibrillation management. Is often sufficient to improve the AF-related symptoms. The primary indications for the rhythm control using the cardioversion in antiarrhythmic drugs and or catheter ablation is the reduction of the AF-related symptoms and improvement of the quality of the life. To initiate the long-term antiarrhythmic drug needs to balance between the symptom burden and the possible adverse effect drug reaction, particularly drugs induce pro-arrhythmia or extracardiac side effect and the patient preference. Catheter ablation is a well-established treatment for the prevention of the atrial fibrillation recurrences and alternative to the atrial antiarrhythmic drug. Identification of the and management of the risk factors and concomitant diseases is the integral part of the treatment of the atrial fibrillation. Thank you for your kind attention. So I'm stop here for my presentation. I would like to introduce the second speaker. Second speaker is the Associate Professor Dr. Ted Lesway. Dr. Ted Lesway is the Senior Consultant Cardiologist, Cardiology Department, Yangon General Hospital, University of Medicine 1, and then she is working together with me, and then she is also specializing in electrophysiology and cardiac pacing, and then she was also trained in the National Heart Center, Singapore for the cardiac electrophysiology and pacing. And then she is also graduated from the University of Medicine 1, also finished well-trained in the internal medicine, finished the master's degree in the internal medicine, also member of the Royal College of the Physician, of the Fellow of the Royal College of the Physician. She finished the cardiology doctorate in the 2015, and then also joined the training in the cardiology, also in the cardiac electrophysiology and pacing. And now she is practicing with us, me, for the cardiac electrophysiology and pacing. Without further introduction, I would like to call the Dr. Teles for presenting about the approach, current approach for the stroke prevention and atrial fibrillation. Dr. Teles, please.
Thank you very much, Manuel, for your kind introduction. I'm really honored to be a speaker in this 67th MMA conference. Today, I'm speaking about the current approach for the stroke prevention in atrial fibrillation. The key topics I will be talking about is the 4SAF scheme and the integrated ABC pathway, the stroke risk assessment, bleeding risk assessment, stroke prevention therapies and recommendations, how to deal with the anticoagulation for AF in the acute coronary syndrome, chronic coronary syndrome, and for the patients who underwent the percutaneous coronary intervention, and stroke prevention for the recurrent attacks in the AF patients. This is the 4SAF scheme that the previous presenter have already talked about. The first one is the stroke risk assessment. It is very important and it is usually done by the Charles-Bosco. This is the components of the integrated AF management. In the integrated AF management, the patient is the center of the treatment. So it should be the patient-centered care, and patients should be explained about the diagnosis and the treatment options and the progress about the disease and the outcome of the treatment. So firstly, the optimized stroke prevention is very important because stroke is very disabling and patient with the stroke can have a unproductive life. And the other symptom control for the rate and the rhythm are already explained by the previous speaker. This is the integrated ABC pathway for the management of stroke. Now in the 2020 ESC guideline, it is stressed about the CC to ABC approach. Firstly, confirm the AF and then characterize the AF by the 4SAF scheme and the ABC pathway, A for the anticoagulation, avoid stroke, B for the better symptom control, and C for the treatment of the comorbidities and the cardiovascular risk factor management. For the A, this is about the anticoagulation and how to avoid stroke. Firstly, we identify the low-risk patients by the Charles-Bosco. Who are the low-risk? Charles-Bosco 0 for men and 1 for women are usually in the low-risk group. And we should offer the stroke prevention treatment if the Charles-Bosco is more than or equal to 1 in male and more than 2 in female. And we should assess the bleeding risk, address the modifiable bleeding risk factors in those who will be on the anticoagulation treatment. And then followed by the choosing oral anticoagulation based anticoagulants, whether NOAC or DOAC, or whether the vitamin K antagonist with the well-managed DTR. So firstly, we should assess the stroke risk. Usually, there are so many stroke risk factors in patients with AF. So most commonly studied clinical risk factors, these are usually included in the Charles-Bosco. And the other clinical risk factors also include the impaired renal function, obstructive sleep apnea, HOCM, hyperlipidemia, smoking, metabolic syndrome, and malignancy. But the most commonly studied clinical risk factors are included in the Charles-Bosco. Here is the Charles-Bosco. C for the congestive heart failure. So is the patient having clinical heart failure or objective evidence of moderate to severe LV dysfunction or hypertrophic cardiomyopathy? If there is one, the patient will have 1 point. If the patient present with the decompensated heart failure, irrespective of the LVEF, that means heart failure with reduced ejection fraction and heart failure with the preserved ejection fraction will be included in this category. And another one is H is for the hypertension, or if the patient is on the antihypertensive therapy. And age is the continuous risk factor for the stroke, and age more than 75 years and above will have 2 points. And another one is D is for the diabetes mellitus, whether the patient is having treatment with the oral hypoglycemic agents or insulin, or having blood glucose or fasting glucose of more than 125 milligram per deciliter. If the patient has previous stroke, TIA, or the thromboembolism, there will be 2 points for the score. And if the patient has the vascular disease like coronary artery disease, previous myocardial infarction, peripheral arterial disease, or the aortic plaque, the score will be added. And if the patient is within the age of 65 to 74 years, there will be 1 point. And if the patient is female, the the patient will have 1 point. But female category is not the risk factor, but is a risk modifier in the Chart-Bar score. So there is an association between the Chart-Bar score and adjusted stroke risk. If the patient has one point in the Chart-Bar score, he or she has the 1.3% per year of adjusted stroke risk. If the patient is having more and more score, the risk will be more and more higher. So after assessing the Chart-Bar score, we will need to assess the bleeding risk. There are so many scores for assessing the bleeding risk, but we usually use the Hess-Bled score. H for the uncontrolled hypertension, when the systolic blood pressure is more than 160. We will need to look for whether the patient has the renal or hepatic dysfunction, whether the patient is undergoing dialysis or transplant, or the serum creatinine is more than 200 micromole per liter, or the liver impairment with the cirrhosis, with the bilirubin 2 times upper limit normal and the enzymes 3 times upper limit of normal. Whether the patient is previous stroke or bleeding history or predisposing to the previous bleeding history, and lay-by INR, that is when the patient is taking the vitamin K antagonist like warfarin, when the time in therapeutic range is less than 60%, it will score 1 point. And if the patient is in the elderly, it will add to the score. And we should ask the patient about the drugs or the excessive alcohol drinking history, because the concomitant use of antiplatelet or NSAIDs and excessive alcohol 14 units per week will add 1 point for the Hess-Bled score. So the maximum score in the Hess-Bled will be 9, and Hess-Bled score of 0 to 2 is regarded as the low risk of bleeding. In the assessment of the Hess-Bled score, we should look for the non-modifiable and modifiable scores. These are the non-modifiable scores like age more than 65 years, previous major bleeding, hepatic dysfunction, genetic factors, being a diabetic, having a cognitive impairment or dementia. These are the non-modifiable scores in the Hess-Bled score. But there are potentially modifiable and modifiable scores that I have mentioned in this table. So one thing is that we should assess for the modifiable bleeding risk factors, and we need to correct the bleeding risk factor. For example, if the patient is having elevated blood pressure and the when blood pressure is controlled well by the antihypertensive, the score will be deducted 1 point. If the patient is having excessive alcohol intake, we should educate the patient to refrain alcohol, so there will be reduction in 1 point in the Hess-Bled score, so that Hess-Bled score will be lower than the previous episode, and then patient will have the less chance of bleeding. So these are the absolute contraindications to the oral anticoagulants. When the patient is having the active serious bleeding, the source should be identified and treated first. And when the patient is having the associated comorbidities like severe thrombocytopenia, severe anemia, which is still under investigation, and recently high risk of bleeding events like intracranial hemorrhage, these are the absolute indications for oral anticoagulation, although the patient may have indication for the anticoagulation treatment according to the Chart-Bar score. So what are we doing in the clinical practice? When the patient is eligible for the oral anticoagulation, we should identify the risk by the Chart-Bar score. This is step 1. With the Chart-Bar score, we can identify the low risk patient and the high risk patient. What is the low risk? Low risk means Chart-Bar score 0 in men and 1 in women. So this is the low risk. If the patient is in low risk, we should not give antithrombotic treatment like NOAC or warfarin. If the patient is not in the low risk, that is when the Chartwell score is more than 1 in male or more than 2 in female, we should look for the Hess-Bled score. When the Hess-Bled score is more than or 3, that is having the high bleeding risk, we should address for the modifiable bleeding risk factors that I have mentioned before, and the flag up the patient for the regular review and follow-up. We should ask the patient to attend regular and early follow-up to calculate the Hess-Bled score again, and we should assess the bleeding risk. After doing all these risk scores and informing the patient about the diagnosis and the treatment options, if the Chartwell score is more than 1 in male and more than 2 in female, the oral anticoagulation treatment should be considered. This is the class 2A indication. When the Chartwell score is more than or equal to 2 in male and more than or equal to 3 in female, oral anticoagulation is recommended. This is highly recommended, class 1A indication. So in the patients with the class 1A indication and in the patients with the class 2A indication, we can begin the NOAC, that is newer oral anticoagulants, and we can also call them the DOACs, direct oral anticoagulants, or vitamin K with the INR in the high time in the therapeutic range. And nowadays, the NOACs are generally recommended as the first-line therapy for the oral anticoagulation. So what will we choose? The NOAC or DOAC or the vitamin K antagonist, the warfarin. So after being assessed the Chartwell score and the Hess-Bled score, patients should be explained about the diagnosis and the treatment options. In our country, the patients are not financially sound, so that the newer anticoagulants like rivaroxaban or episaban, they cannot afford. It might cost a fortune for them, so that they can be discussed about taking warfarin. So in taking the warfarin, patients should be assessing very frequently at the outpatient clinic at the initial part, and then maybe later on they may attend the clinic maybe every month or maybe every 6 weekly to assess the INR. So if the clinician is having a dilemma about giving warfarin or the NOAC, the same TTR score can also be used. If the vitamin K antagonist is being considered, we can calculate the same TTR score with this score. And the score is 0 to 2, we can consider the vitamin K or the NOAC. But if the score is more than 2, it is less likely that patient is having less likely to achieve a good time in therapeutic range on the warfarin. So we should advise patient to have the NOAC. The better point of the NOAC is that the patient does not need to come to the clinic very frequently for adjusting the dosage. So if the patient is living in a remote area like a northern Kachin state or the very much in the southern part of the country, if they cannot come to the clinic very frequently, they can be on the NOAC if they can afford the medication. If the warfarin is used, the time in therapeutic range should be ideally more than 70%. So they should have a therapeutic INR in the therapeutic range for most of the time in the patients with warfarin. So what are the stroke prevention therapies? The vitamin K antagonists and non-vitamin K antagonists like dabigatran, episaban, rivaroxaban, and endoxaban. In our country, we can have the rivaroxaban and episaban, and we can see some patients on the dabigatran who have been coming back from abroad for the AF management. And other antithrombotic drugs like antiplatelets have literally no role in the prevention of stroke in atrial fibrillation. Here is just to memorize the mechanism of action of anticoagulant therapy. These are the direct factor 10A inhibitors, the episaban, endoxaban, and rivaroxaban, and the dabigatran acts on the factor 2A, and the warfarin acts on the factor 2, 7, 9, and 10. So what is the difference between the NOACs versus vitamin Ks? They have comparable benefits, but according to the RCTs, NOACs have a 19% reduction in the risk of stroke or systemic embolism, 51% reduction in hemorrhagic stroke, 10% reduction in all-cause mortality. It seems good. And non-significant 14% reduction in the major bleeding risk, and they have 25% increase in the GI bleeding. So NOACs have a higher risk of GI bleeding. This is the dose selection criteria for AF. In our country, we have rivaroxaban and epizaban. So rivaroxaban standard dose is about 20 milligram OD, and the reduced dose is about 15 milligram per day. And the indication for the reduction of the dose is the creatinine clearance. And the epizaban is in the dose of 5 milligram BD, and the dose should be reduced if the patient is elderly, more than or equal to 80 years, body weight is less than or equal to 60, and the serum creatinine is high. Dabigatran, the standard dose is 150 milligram per BD, and lower dose is 110 milligram BD. And the dabigatran dose should be reduced in the elderly patient and patient with the concomitant use of verapamil and the increase in the bleeding risk. So what is the recommendation for prevention of thromboembolic events in AF? So NOACs are usually recommended. This is the class 1A. If the child bar score is 0 in men, 1 in women, not offer antithrombotic. Child bar score more than 2 in men, more than 3 in women, oral anticoagulant is highly recommended. This is the class 1A. So if the child bar score is 1 in men, 2 in women, you can give oral anticoagulant, but the recommendation is less. This is 2A recommendation. And the risk score-based bleeding risk assessment should be used as all time. The HESBLED score should be used for the bleeding risk. If the HESBLED score is more than 3, there is the high risk of bleeding, and patients should be asked for the frequent clinical review and follow-up, and we should find out the modifiable bleeding risk factor and correct as much as possible. And the stroke and bleeding risk assessment at the periodic intervals should be done. And the patient with AF with a low risk of stroke, first assessment of the stroke risk at 4 to 6 months after the index evaluation. That is the class 2A indication, because you may be assessing a patient with the age of something like 74, over 74, something 74.5 years. Maybe in the 6 months time, he or she will be 75, and the risk will be added 1 score. That is why the after index evaluation, you should assess the risk again at 4 to 6 months interval at clinic visits. If the vitamin K is used, the INR should be 2 to 3, and time in therapeutic range should be more than or equal to 70%. And here are the points that I would like to highlight. What about the antiplatelet therapy? We cannot afford NOACs. We cannot do the regular follow-up and check-up of the prothrombin time or INR with the warfarin. Can we give antiplatelet as a successful prevention of the stroke? No, this is not recommended. This is class 3. So when we assess the bleeding risk is high. Is it a contraindication to the anticoagulation? So estimated bleeding risk should not in itself guide the treatment decision to use the oral anticoagulant. So clinical condition of the patient should not condition the indication of the thromboprophylaxis as well. These are the class 3, so this should be avoided. What about the AF patients having the acute coronary syndrome and having the PCI? In this figure, it is clearly pointed out that when the patient is having acute coronary syndrome, that is acute ST elevation MI, when the patient is undergoing the PCI, in the first phase, we can give aspirin for the 1 month, P2Y12 inhibitor, that is preferably clopidogrel for 12 months, and the NOAC. Initial 1 month, we have 2 antiplatelet plus 1 NOAC. And the P2Y12 inhibitor should continue to 12 months. And then after 12 months, that is 1 year, we can stop clopidogrel and then give the NOAC for the long term. And in the patient undergoing the PCI in the chronic coronary syndrome, like chronic coronary artery diseases, after doing the PCI, we should give aspirin for the 1 month, P2Y12 inhibitor, that is clopidogrel, preferably clopidogrel for 6 months. And if the patient has low bleeding risk, but the patient has having high risk of stent thrombosis, we can extend to 1 year. And after 1 year, both the antiplatelet will be stopped, and then we can continue the NOAC. So, sorry. the bleeding risk and the thrombotic risk usually should be assessed by the cardiologist who is performing the PCI and the plan for the duration of the antithrombotic therapy. So these are the recommendations for the patients with AF, acute coronary syndrome, who are undergoing primary PCI, and the chronic coronary syndrome who are going the PCI. So NOACs are in preference to the vitamin K antagonist. If the risk of thrombosis is very low, and if the bleeding risk is very high, higher than the risk of stent thrombosis, we can stop the aspirin in less than or 1 week duration. In the previous figure, it was shown that the aspirin should be given for 1 month. If the bleeding risk is very high, we can stop the aspirin in less than 1 week. This is the class 1 indication as well. Also in the chronic coronary syndrome, we can stop aspirin in less than 1 week duration, but continue clopidogrel for up to 12 months in the ACS, up to 6 months in the chronic coronary syndrome. And after that, the clopidogrel is stopped and the NOAC should be continued. What about AF patients with acute ischemic stroke and hemorrhagic stroke? Usually the AF-related strokes are fatal and disabling, and there can be early recurrences, and there can be hemorrhagic transformation. And when they have the hemorrhagic transformation and ICH, there can be higher morbidity and mortality. So what about the timing of oral anticoagulation in the acute ischemic stroke? The high-quality RCTs are still lacking. The opinions are still based on the expert consensus. In the previous guideline, it is recommended that the patient is having TIA. The anticoagulation can be started 1 day after the acute event. If the patient is having the mild stroke with the low NIHSS score, the anticoagulation can be started 3 days after the event. And if the patient has moderate stroke and the severe stroke, the patient should undergo recheck CT or MRI for the microbleeds, and then can be oral anticoagulation can be started either 6 days after the acute event or 12 days after the acute event. This is the recommendation according to the AHA acute stroke ASA guideline for the management of patient with acute stroke with the AF. So oral anticoagulation can usually be restarted between 4 and 14 days after the onset of the neurological symptoms. This is the class 2A-B recommendation. What about the long-term secondary stroke prevention? Shall we add aspirin to the OAC? No. Shall we give warfarin with the supratherapeutic INR, that is INR more than 3? No, there is no evidence to improve the outcome. In the case of the anticoagulation, NOACs have the better efficacy in secondary stroke prevention and better safety regarding the ICH. And the good adherence to the OAC should be recommended at all times. What about reinitiation of anticoagulation in post-intracranial bleeding? We can assess the risk of recurrent ICH, and we have to address the modifiable bleeding risk factor. We need to weigh the risk and benefit of restarting reinstitution of the OAC. If there is less risk of reinstitution of the OAC, we can restart the oral anticoagulation 2 to 4 weeks after the ICH. If there is risk, we can offer the left atrial appendage occlusion to avoid the previous stroke in case of ICH and the AF, or we can choose no therapy, no stroke prevention therapy, according to the patient risk of having the recurrent stroke and risk of having fatal intracranial hemorrhage. So in patients with the oral anticoagulation, this is how to manage the bleeding complication. So when there is bleeding, compress the bleeding site, and then we should check the hemodynamic status, PP, coagulation parameters, blood count, kidney function. What anticoagulant if the patient is taking? Vitamin K antagonist. Is it minor bleeding? And then we can stop the warfarin for a while to let the INR go down below 2. If moderate to severe, we can give the fluid replacement and then vitamin K injection. Severe and life-threatening bleeding should be treated with a prothrombin complex concentrate of FFP. In the NOAC patients as well, if the minor bleeding, NOAC should be stopped only for 1 day. If moderate bleeding, should consider to add the oral charcoal. if the NOAC is recently ingested less than 24-hour duration. In the severe life-threatening condition, we can give prothrombin PCC or the FFP if available. So here are my key messages. So for the structural clinical risk score-based assessment of the individual thromboembolic risk, we use the CHART-VAS score as the first step. And then in the patient with AF and risk factor for stroke need to be treated with oral anticoagulant for the stroke prevention. In NOAC eligible patients, NOAC are preferred over vitamin K antagonists. And we should assess the bleeding risk score by the HES-BLED score, and we should address the modifiable bleeding risk factor at all time. And we should manage the modifiable bleeding risk factor so that patient have low bleeding risk. And in the patient with the acute coronary syndrome undergoing the uncomplicated PCI, early discontinuation of aspirin and switch to dural antithrombotic therapy with the OAC and the P2Y12 inhibitor, that is clopidogrel, should be considered. So this is the end of my presentation. Thank you very much for your kind attention.
Thank you, Dr. Leslie, for your informative presentation. So we have the time constraint is that we have only 5 minutes left, and then we have the many questions from the audience. So the first question is how do we consider for the persistent AF for the rhythm control approach apart from the symptom? So this one is I should answer as because for the selection of the either rhythm control or choosing of the rhythm control or rate control is that depends on the many factors. So initial stage, and we start with the rate control. After that, and I already talking about who are the benefit from the rhythm control, who are the benefit from the rhythm control. So in the case of the persistent AF, patient doesn't have any structural heart disease. Duration of the AF is shorter, and the structural heart disease means the left atrial data is very important. So you should choose for apart from if the patient is a favorable condition, patient doesn't have the many symptoms related to the AF, you try to choose for the rhythm control approach. If fail, and then you follow with the rate control. So finally, most of the cases at that time, and you need to look at how many comorbidities and then how severe the cardiovascular risk is very important. So this is my answer. Another question is how to use for the patient with the not tolerate for the rate control in the beta blocker. You can use for the immuno. This is the answer. So another question is for the Dr. Leslie, when they are going to resume for the OAC, like the NOAC for after the intracranial hemorrhage. I think you already presented in your presentation.
Yes.
So anyway, you can answer for that.
After having the intracranial hemorrhage, you can resume the OAC after 2 to 4 weeks of having intracranial hemorrhage, but you have to weigh the benefits of preventing further ischemic stroke and the risk of having another another intracranial hemorrhage. And you should address the other bleeding risk factor and try to lessen the bleeding risk factor as well.
So the last question is the success rate of the catheter ablation. They're asking about the success rate of the catheter ablation in the atrial fibrillation. The success rate of the catheter ablation is I already showed that what are the poor outcome in the catheter ablation. If your patient is a very severe cardiovascular risk factor, too many cardiovascular risk factor, too many and associated with the comorbidity. So that is why the outcome is very poor. If your selection is very good, and then the outcome, the success rate is very higher. So depend on the center and the experience of the person also. So this is indeed for the electrophysiology, and then the how to ablate for the mechanism for just for the pulmonary vein isolation or the target for all the signal from wherever the signal, and then you going to ablate is another way. So these are the many technical approach for the AF ablation. So and the important thing is the selection of the patient is very important. And then in our Yangon General Hospital, we have not much experience, and then we highly selected the patient, and then for the higher the success outcome, and then to prevent the complications. So now in the time is only 1 minute left. So we would like to conclude this section, and also thanks to the 67 Myanmar Medicare Conference for having us allowed to the present and having us for the allowed us for the presenting the atrial fibrillation topic here, and then also thanks to the Pfizer Biotech for the sponsoring this section. Then also thanks to all the participation for all the participants for attendees for the active participation, asking the too many questions. I have answered some questions by with the message. Okay. Anyway, thank you very much for thank you very much for all of you, and also have a nice evening. Thank you. Bye bye.